cum laude and at the top of his class. He earned his medicine degree from Stony Brook University School of Medicine. He then completed his residency training in internal medicine at Rogers Albert Wood Johnson University Hospital, followed by the training in both cardiovascular disease and interventional cardiology at the North Shore University Hospital and Long Island Jewish Medical Center. During his training, he was mentored by some of the most skilled and the highest volume interventional cardiologists in the country. In addition to his commitment for excellent patient care, Dr. Ho has contributed manuscripts to leading cardiovascular journals and presented at multiple national and international conferences. Dr. Ho, welcome. Thank you.
Thank you.
Thank you everyone for having me. Thank you Dr. Wang for introducing me. So, I was born in Beijing. Both of my parents were doctors in China. And when they came here, they wanted me to become a doctor. So I became a doctor. And here I am. So I scroll down to the next slide.
Yes.
I don't think it's working.
Scroll wheel. Scroll wheel.
Scroll.
Yeah, it's okay now.
Okay. So unfortunately, I don't have any disclosure. So today my talk will be on heart failures, and especially in patients who had a myocardial infarction. So heart attack is still a very common pathology in this country, and it's often underdiagnosed in this community. And a lot of patients, even after successful resuscitation in the hospital, they develop heart failures in subsequent years, and some of them even develop, during the index hospitalization. So this is one of the studies in the past where it showed that 34% of the patients who was admitted to MI developed heart failure while in the hospital, and up to 70% of patients develop heart failure within 5 years after the hospital discharge. And the mortality and heart failure rate remains stagnant despite the PCI technologies and more advances in this field. So PCI, stents in general has become the standard of care, but there has been an unchanged outcome in terms of heart failure and mortality since the early 2000s. So, in interventional cardiology, we judge our efficacy by the door balloon time, and the national standard is within 90 minutes. And you can see on the chart, over the years, we have been getting very good at getting the arteries open very quickly. So the average door balloon time in the early 2000s was 80 minutes, and nowadays it's in the 60s. And in areas like New York City, where there's hospitals everywhere, the door balloon time is actually much shorter. In North Shore Hospital at LIJ, the average is around 40 minutes. But despite all this, the mortality, in-hospital mortality and overall mortality has essentially been the same over the past 20 years. There's a lot of trials in the past that try to basically tackle this important problems. How do we improve heart failures in those patients, and how do we improve mortality in those patients? Devices such as distal protection, thrombectomy, novel medications, and a lot of other stuff have not really shown any changes in the heart failure and mortality aspect. So epicardial flow does not always is equivalent to myocardial reperfusion. So the stents, the smallest stents we have on the shelf is 2 millimeters. We can restore the epicardial blood flow but there's a lot of capillaries and small vessels distal to those large vessels that are not treated despite stents. So 90% of the myocardial flow are supplied by capillary and microcirculation. So to really treat this problem, we need to restore both epicardial and also microvascular flow. And there has been studies in the past that demonstrate that microvascular obstruction and infarct size has a very strong correlation with one-year outcomes. So MI outcome can only be improved by tackling two issues and not just focusing on the one issue opening the artery in this block. So in these studies where they use a cardiac MRI as a marker for infarct size and show that essentially that a lot of the anterior wall MI patients, they have a lot of microvascular obstruction, and even a small change, a small decrease in infarct size and improvements in microvascular circulation leads to a very drastic increase in patient outcomes, improvements in patient outcomes. And in the infarct size, it's sometimes very hard to correlate because not every patient gets discharged, gets a full workup of cardiac MRI, echocardiogram, stuff like that. So 25% of the patients who were treated with PCI has nearly 30% of the left ventricular mass residual infarct. And this again showed that small percentage change in the infarct size has a very strong correlation with their patient outcome. So the technology I'm talking about today, it's called SORAX. It's essentially a super saturated oxygen therapy that's only available in a very small number of hospitals. And the current FDA indications for patients who had an anterior MI and had their symptom onset within the first 6 hours. And essentially what it is that it's a localized delivery of a super oxygen to the vessels and to the microcirculation of those vessel supplies. The reason why this technology is only limited to certain hospitals is because even though it's FDA approved, it's not currently reimbursable by Medicare. And the equipment is very expensive, and it also takes a lot of time in the hospital that's not reimbursed. So what it does is that after we open the epicardial vessel during the acute MI, we re-hook up the patient to this machine, and we deliver up to 1 hour of super saturated oxygen through the same catheter to the same vessel. And the technology, what it's supposed to do is that the high concentration of oxygen is a higher gradient and allows for a more readily diffusion of oxygen to the endothelial cell and myocardial tissues. And by doing that, it relieves the capillary constriction and also relieves the edema within those tissues. And because of this 1 hour of intense high oxygen circulation, microvascular flow is restored and the ischemic myocardium is reperfused based on a lot of the studies we have done. And this is the animal studies where they essentially mimic the anterior myocardial infarction in animals, and they did a nuclear scan with stent alone and with stent plus the super oxygen therapy. And you can see, the yellow part is where the increased uptake. So the more yellow means more perfusion of the myocardium. And you can see there's a drastic difference between top and bottom in terms of the perfusion and the reuptake. So overall, the predictors of heart failure after a myocardial infarction, obviously follow-up with cardiologists and also mental management of goal-directed medication is key, but we want to improve the patient outcome from the very beginning when they first show up in the hospital, so that you set them up for success down the road. We want to improve the microvascular dysfunction, improve their perfusion, and reduce the infarct size. And in the long term, this will lead to decrease in LV remodeling and the improvements in systolic and diastolic function. So this is one of the cardinal studies of this technology, where they compared PCI versus PCI plus this superoxygen therapy. And there's about 6.5% absolute reduction in infarct size. And relatively, it's about 25% reduction in infarct size. In addition, this also decreased LV size, and which lead to a decrease in LV remodeling. And in both studies, there's about 8 to 11% decrease in the size of the LV, left ventricle. So this goes back to the heart failure post-STEMI. And the studies that I conducted in North Shore Hospital is essentially in a real world cohort of patients. Does this actually work in the patient we see every day in the hospital? So since 2003, when this technology first started using in North Shore Hospital, we had about 18 cases of such patients. And the majority of them are the anterior wall MI, and some of them are right, some are left main, and some of the patients had a cardiogenic shock as well. So essentially, we exclude the patient who didn't really meet the criteria, the shock patients, the patients that we didn't really have a chance to follow up, and we matched those patients with patients who got stents alone. And we compared their ejection fraction upon discharge, also their ejection fraction on echo, 90 days after follow-up. So this is all the patients in the control group, and we compared their ejection fraction at the hospital discharge with the ejection fraction 90 days. So you can see, most of those patients had some improvements. Some patients even had a decrease in the ejection fraction. But overall, 64% of the patients had at least 5% increase in their ejection fraction on echocardiogram. And you compare that to the patient who received both the stents and also the superoxygen therapy, virtually every single one of them had a very significant increase in the ejection fraction upon discharge. And none of those patients came back for hospital for heart failure readmission. So using a baseline LVEF in both groups, there's about 10% mean average increase in ejection fraction in both groups. And this is a graphic demonstration of the significant improvements in their heart function. So the other thing on top of it is the technology and the role of cardiogenic shock. As everyone knows, cardiogenic shock has a very high mortality. Overall, in this country, someone diagnosed with cardiogenic shock in the hospital, their overall mortality is about 50% to 60%. And a lot of times, our option is limited to mechanical support of either a balloon pump or Impella or even via ECMO. We want to see if this technology can be something in addition to mechanical support to really treat the underlying issues. And the 4 patients that developed cardiogenic shock in the hospital, fortunately, most of them, all of them actually survived with the combination of mechanical support and superoxygen therapy along with PCI. And we're still following them up, and all patients we see they truly had improvements in their ejection fraction. But this by itself, I think, showed that it's at least safe in this very sick patient population. So this technology actually have a lot of utility in other fields. Pulmonary embolism and cerebral infarction are the 2 areas that we're looking to expand, where we want to see if this technology can also apply to other organ systems. And this is actually one of the first patients that we treated recently and actually made the news. This patient actually was playing golf in the nearby golf course in Manhasset, and suddenly developed, anterior MI in the ER and went to cardiac arrest. And we eventually were able to resuscitate him, put on this new technology, and he's essentially back to normal life with a normal ejection fraction, despite suffering from a major anterior wall myocardial infarction. And this is him and our follow-up visit in the clinic. So this is my last slide. So if you want any questions, feel free to ask. And this is my cell phone number. I have a clinic in the Crossing building, and feel free to contact me with anything.
All right, thank you, Dr. Ho. Why he credits golf, not the cardiologist?
I'm sorry.
Why he credits golf, not the cardiologist in the news?
It's he's actually a very interesting guy. He actually is he was playing golf and he wanted to finish a set before his daughter was taken to the hospital. So right before he finished his set, he actually went to cardiac arrest on the field in the golf course. So they have to resuscitate him while basically on the grass and then brought him to the hospital.
All right, thank you, Dr. Ho. Wonderful talk.
Thank you.
It's really kind of like introduce a very new technology to help the patients recover after the heart attack. Dr. Ho have an office in Flushing. Yeah, you can also introduce your clinic what you can do in the community a little bit. Yeah.
Yeah, so I'm mostly concentrated in interventional cardiology in the hospital, and we see general cardiology patients as well. But my main goal is to bring new technologies in cardiology, such as PCI, transcatheter valve replacements, and new technology like this to a community where, in my opinion, is underrepresented. And I speak fluent Chinese, and really want to bring what I learned in fellowship and training to this community.
All right, thank you, Dr. Ho. Yeah. Any questions?
Yeah, I would like to know, is this all treatment except invasive procedure?
Yeah, so how it works is that the patients, when they get to the ER with MI, we treat them as if there were any other, myocardial infarction. We bring to the cath lab, we open up our artery with stents, and then we spend an extra hour post procedurally to do this new technology. We use the same catheter, the same equipment, but hooked up to a different equipment to deliver the super oxygen therapy. And we do this 24/7, 365. It's really the treatments post PCI to optimize the results.
What's the selection criteria for these treatments?
Like I mentioned before, it's a very expensive treatment that's not reimbursed by Medicare or any insurance at this point. So every procedure we do is really, the hospital has to take a financial hit because of this. And on average, the hospital takes about $30,000, $50,000 per case. So right now, where this technology is most useful is patients who have early onset of symptoms within 6 hours, and they're otherwise healthy, meaning they don't have any prohibitive morbidities like terminal cancer, brain tumor, things like that. And it's mostly limited to anterior MI, where most of the benefits are shown. So.
Do you recommend oxygen after they were discharged from the hospital?
No, so the question is do they oxygen after discharge. So the oxygen supplement we're taking in the hospital is through the pulmonary circulation, but this is a very localized delivery, specific to the one blood vessel where the blockage was. So unless patient has other indication for oxygen supplement, I do not recommend.
Any other questions? So is the new treatment available within all North Shore hospital, or only like a certain, like,
So we piloted this technology in North Shore and LIJ along the Jewish Medical Center. And I believe we're the only two hospitals in New York City who offer this. Like I said, this is mostly due to the financials. So, other hospitals don't want to take on the hit. So it's mostly in North Shore Hospital and Jewish. So.